So I don't have any disclosures or conflict of interest regarding this topic. And we have taken informed consent from all the patients whose data I'm presenting today. To define tubeless anesthesia is a specialized skill of providing tubeless field without using a definitive airway, still providing appropriate strategy for oxygenation and anesthesia. If you see this first picture, there is a tumor or the vocal cord polyps in the anterior commissure of the vocal cords, and there is a tube in situ. When this tube is removed, particularly in a surgery of the posterior vocal cord, this is the picture we get. This is essentially a pictorial representation of what is tubeless anesthesia. Unfortunately, we don't have any universally accepted definition. What is globally accepted as tubeless anesthesia. This definition is purely framed for this presentation from me. What is the requirement of tubeless anesthesia? Why it is required? Conventional endotracheal anesthesia maintains airway patency. It protects from aspiration, secures airway, also prevents gastric insufflation. Let us take this picture. There are vocal cords in the posterior part, the tumor in the posterior part of the cord. For the same patient, if I put an endotracheal tube, the vision will become something like this. And it is obscuring the surgeon's view. It is also preventing the surgeon's accessibility. Thereby, it prolongs the total duration of surgery. What are the inherent risk of tubeless anesthesia? Since we don't put an endotracheal tube, which is more protective, the airway, there is always a airway is at a risk of collapse, risk of aspiration, and airway is not secure, and there is a high chances of gastric insufflation. This is also shared airway, which has got a potential to airway compromise at any point during the surgery. It becomes a very challenging for an anesthesiologist to maintain a strict balance between adequate depth of anesthesia as well as spontaneous respiration. More the drug, patient may start moving in during these procedures. And unfortunately, there is no accurate monitor of end-tidal carbon dioxide during these procedures. What are the goals? As an anesthesiologist, we should have a goal for every anesthetic procedure we do. Here, to provide an with very minimal or no movement of the vocal cord to the surgeons, yet maintaining oxygenation, ventilation, and adequate depth, so that adequate depth maintaining doesn't mean patient should become too deep and you should take the larger time for the emergence. It should also prevent, the depth should also prevent the pressor response for the suspended laryngoscopy. It should also minimize the fire hazard in case if you use a laser tube. And yet, though we are not putting a tube, there should be plan A, plan B should always be ready to secure a tube if the need arises. So it requires a careful selection of the patient. All patients, we cannot do tubeless anesthesia. There is certain prerequisite. The tubeless anesthesia is not a single man show. It requires a team approach with a open communication among all the team members. The airway technique used should form a part of common agreement strategy between all the members of the team, including a surgeon, technicians, familiar with all the aspects of utilization and safety issues. As already discussed, the primary and a backup plan should be ready well in advance, and we should also ensure adequate equipment and trained personnel before conducting tubeless anesthesia. So shared decision making is always a key to the success. There is a hidden challenges whenever we do tubeless. Many a times the team members may not be very familiar with what we are going to do, and also the critical nature of an airway narrowing and a limited reserve, meaning whenever particularly we handle a case of tracheal stenosis, where the tubeless anesthesia becomes challenging and it is deemed necessary, we can know what is the extent of a depth, what is the extent of a tracheal stenosis, what type of tracheal stenosis, but it never gives us an information about how the airway will react to general anesthesia in this situation, and whether we are going to ventilate, ability to ventilate or obtain a similar laryngoscope view is not guaranteed as we get in a OPD basis endoscope. So these are certain challenges while doing the tubeless anesthesia. What are the indications? The common indication most of us would have provided a tubeless anesthesia is during a simple direct laryngoscopy and biopsy. The other conditions include the laryngeal hemangioma, laryngeal web, inflammatory lesions of the larynx, the tumors, dynamic and functional assessment of the vocal cord, and very commonly now for a voice therapy, vocal cord Teflon injection. The tracheal condition includes the diagnostic tracheoscopy, foreign body removal, tracheal stenosis, carinal surgeries, and now a new terminology called NEVATS, meaning non-intubated video-assisted thoracoscopic surgery is coming a big way in European countries. The other OPD procedure or the procedural sedation we use in upper GI endoscopy, ERCP, bronchoscopy, the electroconvulsive therapies, and drug-induced sleep study. These are some of the areas where the tubeless anesthesia is extensively utilized. These are some of the surgeries which we have done in our institute using the tubeless techniques. These are some of the pictures of the vocal cord lesions. This particular researchers from Spain, they published this article called Tubeless Major Pulmonary Resections. In these group of carefully selected patients, they have not used any sort of tubes, including endotracheal tube, the drain tubes, urinary catheters, and they said this new tubeless concept has surfaced as an alternative to double lumen intubation with GA, combining non-intubated spontaneous breathing VATS under loco-regional blockade. That meaning to say, the type of anesthesia should be chosen depending upon the anesthetist experience and demand by that particular surgery. What kind of anesthesia to be used in these cases? Either you can go for inhalational techniques, intravenous techniques, or loco-regional blockade like airway topicalization, or the combination of any of these two called as the hybrid techniques. The inhalational techniques, the problem is of theater pollution. We use either sevoflurane or halothane in these whenever we use inhalational techniques. Intravenous, though the Western textbook extensively say about propofol and remifentanil, because of the non-availability, in India, we use propofol, fentanyl, dexmedetomidine with or without mother relaxants. Or you can use any of the hybrid techniques. The greatest advantage of TIVA here is they maintain a good airway reflex suppression. It separates the anesthesia delivery from ventilation, and the anesthesia can be extended beyond induction to facilitate tubeless techniques. How to oxygenate these patients? This is a great challenge. Either you can use a low flow oxygen techniques using about 10 to 15 liters per minute using nasal prongs, nasopharyngeal airway or coaxial circuit, or face mask ventilation, supraglottic airway devices using ventilating bronchoscopes. Particularly in pediatric, we extensively use ventilating bronchoscopes, high frequency jet ventilator, the device called as supraglottic jet oxygenation and ventilation, which is called SJOV, the tubes, or high flow nasal oxygen technique using Thrive, or the other technique called as perioperative oxygenation techniques. The most commonly used intermittent apneic technique involves induction of the patient either with inhalation agent or IV induction without mother relaxant, depending upon the case. Once we induce the patient and put the endotracheal tube, once the optimization of a ventilation and oxygen occurs, we interrupt the ventilation, remove airway, remove endotracheal tube, and allow for a short surgical procedure by the surgeon. Once there is a drop in oxygenation to less than 95%, maximum allowing up to 90, we resume ventilation and surgeon will stop his surgery. Throughout the period, we maintain either using inhalation, the IV agents, or during mask ventilation, we can use inhalation agent. And this procedure keeps repeating, which is conventionally or traditionally called as a cross-field ventilation technique, where we repeatedly remove and insert endotracheal tube through the surgical field in synchrony with surgical steps on oxygen saturation. The disadvantage is it provides a very transient surgical duration of a period for about 2 to 5 minutes. There is a repeated interruptions. During apnea period, there is a chances of hypoxia and hypercarbia. During ventilation phase, we may cause barotrauma or wallet trauma to the lungs. It can also contaminate the surgical field, and repeated instrumentation increases the chances of airway trauma. Here, either we can ventilate the patient or the surgeon can do only surgery. It is a sort of a musical chair. Once we assume the head end and surgeon assumes the head end at the other time. The high frequency ventilation, most of us are aware, this is a manual jet ventilator which is available in India, where we can set only the frequency that is triggered by our hand, and the pressure can be set somewhere between 3 to 5 bars. The other The equipment available extensively in US, not yet available in India, this is a machine called the Monsoon from the company Accutronics. If you see carefully, we can set the driving pressure somewhere between 1 to 5 bars. The frequency can be adjusted up to 250, from 50 to 250. The FiO2 can be adjusted between 30 to 100%. And even we can set the limits of the pressure. That is a safety period. Anytime that set pressure exceeds, the automatically jet ventilator stops producing the jet ventilation that prevents the valve trauma or barotrauma to the patient. It also has got a button. If you can carefully see the fourth button, there is a laser button. During a laser procedure, the minute you press the laser button, the FiO2 falls from 1 to 0.3. The jet ventilator can be used, the jet ventilation method can be used supraglottically or placing the catheter below the vocal cord subglottic or through the transtracheal route. The four parameters which we are supposed to set is FiO2, respiratory rate, driving pressure ratio, and the other alarm limits. If you don't have a dedicated the transtracheal catheter, we can use a simple suction catheter available routinely in our operating theater, or a tube exchanger, or the supraglottic jet oxygenation or ventilation tubes. The problem with high frequency jet ventilation is the fine movement of the vocal cord, which causes a trouble to the surgeon. It can cause barotrauma, or it can cause implantation of a tumor into the trachea. The greatest advantage being this is an open breathing system, so there is no need for any airtight connection between the airway and the breathing system. This is extensively used during tracheal resection, where the distal end of the trachea, just put a tube, you take this, whatever the dedicated tube with a transtracheal jet ventilator, insert into the distal portion of the tracheal tube or the tracheal lumen, and it can maintain oxygenation and ventilation for a short period of time, which the tracheal resection can be, where tracheal resection can be completed, or the tracheal anastomosis can be completed. This is the tube what I was talking about, supraglottic jet ventilation and oxygenation. It exactly looks like an nasopharyngeal tube, which provides better oxygenation. It doesn't cause the barotrauma. EtCO2 can be measured because there are two lumens, one to provide jet ventilation, the other to provide to monitoring of the carbon dioxide. It maintains the airway patency, and the exact position where it needs to be placed is just above the vocal cord. In case of any difficulty in oxygenation, just pushing the tube inside, it secures and enters the airway. But there is a risk of nasal bleeding. This is a picture where you can see how the SGOV tube is placed, and these are the two lumens. One is connected to the ventilator, transtracheal jet ventilator. The other is connected for EtCO2 monitoring. Coming to the high flow nasal oxygen, it is also called in UK as POINT, whereas Thrive is a patented terminology by Fisher and Paykel, New Zealand. POINT is perioperative insufflatory nasal therapy. Everything is same, is a high flow nasal oxygen therapy. Thrive is mainly patented by Dr. Anil Patel from the Guy's Hospital, London, ENT Hospital, London, where Thrive stands for transnasal humidified rapid insufflation and ventilatory exchange. In HFNO, we are supposed to remember 5H, heated, humidified, high FiO2, high flow oxygen, up to about 70 liters per minute can be provided. The greatest advantage being a mucociliary clearance and comfort to the patient. It provides effective oxygenation and ventilation, avoids the risk of jet ventilation, superior gas exchange compared to the low flow techniques. It generates about approximate PEEP of about 1 to 3 centimeters of water and decreases work of media during COVID period. But always it is important to maintain the airway patency whenever we use HFNO in a paralyzed patient. Otherwise, it also causes the air exchange or the vortices or the sort of a turbulence which creates that does not occur, and patient may desaturate. It also has got inherent problems like hypercarbia when used for a prolonged period, more than 30 minutes. There is no reliable EtCO2 monitoring, though the recent the modification of a device has included a nasal sort of an adapter which can maintain a rough estimation of EtCO2. The inhalation anesthesia cannot be used whenever we use HFNO, and we cannot reduce the FiO2 to 0.3 in case we require during laser surgery. So one of the problem with Thrive, what we encountered and also published is the deep insertion of surgeon's laryngoscope. It isolates the trachea from the oropharynx and prevents any delivery of oxygen to the patient, leading to frequent desaturation. It will be understood better with this picture, where you can see the laryngoscope here, which is completely abutting at the tracheal structure, sorry, the laryngeal structures here, laryngeal aperture. Can you see this particular edge, the beveled edge? And when this happens, we are providing oxygen through the nasal prongs here. You can see this picture. So when it abuts complete to the laryngeal aperture, there is no way whatever the high flow oxygen you're providing can enter the trachea and patient can desaturate. Just ask the surgeon to just retract it by few millimeters. It provides a space for air to the oxygen to enter, and that maintains the saturation. So we have used Thrive in pre-oxygenation, and we have used Thrive as a no desat technique, that is nasal oxygenation during efforts to secure an endotracheal tube. We have used in an unanticipated and anticipated difficult airways. Even we have used this Thrive in the electroconvulsive therapy. This is our publication published in a PubMed journal. And tubeless anesthesia and laser is, we as an anesthesiologist acts as an oxidizer by using the nitrous oxide oxygen or an endotracheal tube. But since we are not using endotracheal tube, one risk factor is eliminated during laser surgery. But still the surgeons are using electrocautery lasers, which acts as an igniters. And the linen supply or the other patient dress or the surgical drapes can act as a fuel. Here, we need to take care about the FiO2. We need to reduce if the provision is there, or we need to eliminate oxygen. And all the staff members in all should be very familiar with the safety principles and relevant management algorithms. The complications more commonly we encountered, if we don't paralyze these patients, are coughing, sudden apnea, laryngospasm, and involuntary movement during the surgery. We have also observed bronchospasm and extreme hemodynamic changes and arrhythmia, particularly when the carbon dioxide starts building up, hypoxia, and hypercapnia. To take home, tubeless anesthesia is used for airway surgeries. It is a specialized, highly skilled technique to be practiced only by experienced clinicians. It improves visibility and accessibility of surgical field. Understanding the physiology and limitation of each technique of oxygen and ventilation is a must, which requires a careful preoperative assessment, planning, communication with the whole team, and it also requires a regular staff education of technical and non-technical skills, which improves the success of tubeless anesthesia. He is Dr. Anil Patel. I had a chance to meet him, and he advises during tubeless techniques. So thank you. Have a safe tubeless anesthesia. Thank you all.
Thank you, Dr. Anil. You can stop sharing. It's a nice concept to know and start implementing also in select cases or of a surgery. And broadly, it's almost goes against our principles of anesthesia per se. When we talk about one extreme of anesthesia, conventional, that is endotracheal intubation with controlled ventilation, with IPPV and everything, what we classically describe. This opposite end, and you are talking about major surgeries being performed without any endotracheal tube and any tube at all per se, including, as you said, for video-assisted thoracoscopic procedures also. So that way, it is a major advance in terms of the airway management. In fact, I would like to inform that one of our PGs has given a thesis where he'll be using Manajet, the jet ventilator. So initially, we had some difficulty in getting used to the system. So what is being done is it is used for short, supraglottic and periglottic procedures. Not, I mean, long-lasting surgeries, because in fact, we want our own surgeons also to be getting used to the system. So we have picked up short surgeries, overall biopsies and other things. So now we have got a grip of the technique basically. And what we have done is we have connected the jet to a point where it should be, it's just placed along the bronchoscope that is used, suspension laryngoscope, it is used by the ENT people. But one major problem for us and which we should try to overcome. And in all the tubeless procedures is the ability or inability to track the internal carbon dioxide. So that is one thing which we have been facing. And one small innovation we try to do is have the sampling tube end just proximal to the laryngoscope blade. Okay, so there we are able to get a tracing and we are able to get a trend. So I think that much is the success rate for our cases, and we have carried forward the research now at this point of time. So what will be therefore your comment on, first of all, the EtCO2 analysis in these patients? So of course, oxygenation is not normally a problem in terms of various techniques, including HFNOs and even jet ventilation. So what could be the further modifications or other options to get the internal carbon dioxide for these patients?
Sir, because it's an open system technique, there is no way we can have an accurate measure of end-tidal carbon dioxide because we're injecting the patient with so large volumes of oxygen. And it is also, it is not a closed system. So there is no way we can get a EtCO2 monitoring. One other way of doing is the arterial sampling. If it is indicated and is ethically allowed, we are able to, because of ethical issues, we are not able to monitor arterial carbon dioxide in all patients. When it was deemed in that particular cases, we have taken in 2 cases and we have observed an increasing trend. The highest duration I have done is about 50 minutes. In that particular patient, we had an end-tidal carbon dioxide, the arterial PCO2 was of about 69 millimeter of mercury. And even the Anil Patel study, where the initial study he has done a maximum duration of an hour. And there also they say there is a high trend, but still it can be managed. But careful selection of the patient and a cooperation of a surgeon is a must before whenever we take up these type of cases.
Yeah, definitely. It needs a lot of constant application of care and mind. In fact, I think our PT has put a query here. That's another technical issue. Basically, we are trying to sample because the tube ends at the distal end of the rigid laryngoscope. Some secretions would also, there's a tendency to interfere with the sampling. So that's what we are finding. We are still trying to streamline because we couldn't find similar researches overall. So we're just trying to have a new type of research and application at this point of time.
Now, Thrive has come up with the New Zealand company. They have come up with a small adapter, sir, and it is researched well. But you can talk to those people, and that research can be done at the institute. There is a small adapter EtCO2, similar to what you are using already to a sampling line connecting to the surgeon's laryngoscope.
Yeah.
With a nasal prong, there is a small adapter. It gives a rough estimation, but some information is available to us.
Yeah, so that's one, because the ABG would be ideally used only for, probably we can justify its use only when you have a sufficiently major procedure where you are trying to attempt it, or a clearly indicated case. So otherwise, ethically we are not correct. And if indeed there are some other options, including transcutaneous options, if at all, those can be attempted, but not practically at this point of time. That I agree. And secondly, as you said, the focus is also to give a good surgical feel to the surgeon. Okay. So our attempts to avoid intubation definitely helps in giving a clearer view for the surgeon. Okay. But using a smaller endotracheal tube and trying to even pass a catheter and HFNC definitely is a good option. But it has got good future, as you say. And in fact, when you talk about the laser procedures, including using the tubeless anesthesia, so HFNC has been used successfully by experienced anesthesiologists in the presence of experienced surgeons. So that's very important.
That's a prerequisite.
That's a prerequisite. So that has been done.
Surgeon should be able to terminate the heart surgery and help us in ventilating the patient, and they should be cooperative.
Yeah. So before I go to Dr. Gurdas sir and others, we have one more question, Dr. Shivanand. And we are happy to tell that 6 to 7 cases we could see prominent visible chest expansion. Yeah, that's another matter of experience. One of the endpoints of success when you use a jet ventilation is to look for a visible chest rise. So what it means is the jet has been directed properly, and the frequency is that much to cause a chest rise. So initially we had problem in getting this also done. Now I think my PG has become an expert now. So he is able to see the chest rise. That's what he has typed in the chat box. Right, Shivaran? Yes, Gurudev sir.
Good evening, Bhaskar and everybody. And as usual, Anil does a very fine job of his lectures. It was very interesting, of course, because I had heard him telling about this tubeless anesthesia lecture so many times, but I had not heard his lecture as such. Today I could hear it. It was very interesting. Thank you, Anil. It was very nice lecture. And this olden days, since many days when tube was not available, when tube was not being introduced, anesthesia was being given without a tube, of course, since Magill's days, or even Martin's days. Of course, it was only a tubeless anesthesia for a long, long time. But now, tubeless anesthesia, as you had said, the indications are mainly the airway surgeries. Because where if you put a tube, it is going to come in the way of the surgeon. So that's how, probably the tubeless anesthesia is becoming popular nowadays for, I think, the airway surgeries, because the majority of the indications you showed were also of airway-related surgeries. And one thing I just want to ask you is because, these high-frequency ventilatory techniques without a tube are there since many, many years. It's almost like probably about 30 years, 35 years. High-frequency ventilatory techniques are there without a tube, especially for the upper airway surgeries. But why they have not become so popular? Anil, can you hear me?
Yeah, Anil, you are able to hear, no? Starts very.
Yes, sir.
Yeah. Yes, sir. Please, can you please repeat, sir?
Yeah, because, high-frequency ventilatory technique like high-frequency jet ventilation, high-frequency oscillatory techniques, high-frequency IPPV, these things are there for the past 30, 35 years, but somehow they have not become very popular. I have not seen even a single high-frequency, machine, ventilatory machine, so that I could use it for the past. So though they have been introduced a long time, so why they have not become so popular?
So because of the increased frequency of complication, even when I was going through the literatures, the high chances of pneumothorax and also the settings, the clinical settings where it was required was very less. It is used only in a dedicated centers where the onco centers or in ENT centers or the airway exclusive dedicated center it is used. One. Second, increased frequency of the complications, the manual jet ventilator was not used. Any other better alternative technique like high flow nasal oxygen is extensively used than the high frequency jet ventilator, sir. One is availability, second is increased rate of complications. That is what the literature, every literature quotes, because of the increased incidence of pneumothorax, because of increased incidence of the desaturation, not able to maintain ventilation, it is not extensively used.
No, because the advantages of high frequency oscillatory technique or high frequency jet ventilation techniques are they produce very good ventilation, like both oxygenation and removal of carbon dioxide will be continuously occurring, and there is absolutely no chance of aspiration, because there is a continuous flow in and out of the airway, no aspiration. FRC is very well maintained because there is a continuous inflation of the chest will be there, better oxygenation will be there. There are so many advantages. As long as there is no upper airway obstruction, there won't be any pneumothorax. So that one has to be maintained. The upper airway obstruction should not occur. So as long as that is there, so high frequency. But I heard what is the main problem is it's a big machine you have to keep inside the OT, because for this high frequency jet ventilation and oscillation, because high frequency oscillation is nearly 2000 to 3000 oscillations per minute. You cannot even, just imagine how fast in and out of the gases can come and out of the, the respiratory system. So that is one thing. Second thing is they make a lot of noise, it seems. So third problem is the cost, the very high cost of these machines. Probably, maybe as you said, that maybe complication rate may also be on the higher side. That's the reason why we are not, seeing these kind of ventilatory machines much. So another important thing I just want to add is now we were talking about HFNOs and HFNCs. Now many of the workstations are also having this provision of providing HFNOs. You don't require a separate HFNO machine or a Thrive machine for providing this. Now it comes with the workstation. So that if you want to go for this kind of an HFNO technique, you can also use that. So that is an advantage with some of the modern advanced workstations. Thank you, Bhaskar. Thank you so much.
So in fact, as you say, sir, this high frequency ventilation is quite popular in the pediatric practice. Pediatric ICU practice, they keep using. In fact, they are more adept in using high frequency ventilation, which is almost a standard setting in many neonatal ICU setups and pediatric ICU setups. And yes, sir, they are being regularly used.
Not for anesthesia. I was talking about anesthesia.
Yes, I understand. I agree, sir. Not for anesthesia. And number two, even in for anesthesia purposes, I have read the literature. Of course, your point is would also be there in terms of the sound and the bulk of the equipment and other things.
Yeah.
But there have been publications where they speak of using high frequency ventilation at current times in adults for anesthesia purposes. So now that you have brought up the point, probably we'll go back to the literature and try to see what type of equipment they did use. So they are available, high frequency devices. When I checked, because I attended a program a few months ago in one of the institutes for laser procedures and tubeless laser procedures. Okay, there, when I was going through the material, literature, there has been mention of using a high frequency ventilation outside of our HFNCs. So that also has been mentioned in adults. So probably machines are available. Probably they can be used practically also.
Okay.
In one of the, I had an opportunity to talk with an institute from Hyderabad. I think the Asian Institute of Gastroenterology, where they use in ENT department, they extensively use this high frequency jet ventilator for tracheal resections and critical stenosis of trachea, less than 3 mm. They just part the cannula. They just buy a time to transect the trachea, and then they put in a flexometallic tube. They ventilate till they prepare the bed for the anastomosis. And once when everything is ready, they remove the cannula and the anastomosis, and they put a tube from above, just oxygenate to maintain oxygenation and ventilation.
So as you said, immobility of the patient is very important. That's the reason. For example, Dr. Prajwal Shetty asked, I think adequate muscle relaxation is also a key factor. So yes, the patient is paralyzed. The patient is paralyzed and you should be able to maintain the airway. So, but again, it's a critical point that you have to keep on monitoring the patient, be ready to interfere, try to secure the airway. That's very important. Anything else related to that, Dr. Anil?
It is unlike an airway algorithm where now the regular mask ventilation is removed. The muscle relaxation is the first, then you check for mask ventilation. Here is a special situation where you should always assure the ability of mask ventilation, then only patient should be paralyzed here. Because we're always dealing with a difficulty airway in terms of narrow or whatever, depending on the indication of the tracheal surgery. Without ensuring a mask ventilation, if you do these techniques, paralysis is done, then we will lose the airway. There is nothing can be done. Even front of neck access is not there in these situations. Because already trachea is narrowed, or it may be a resurgery for the tracheal stenosis or the lengthening of the tracheal procedures. So that is a mandatory before doing the tubeless anesthesia.
Tubeless anesthesia. Dr. Krishna has asked, sir, how is the prognosis and course throughout the procedure? Success rates, how long can we do this procedure? Intubation, re-intubation, it's very difficult.
Routinely for pediatric, particularly the foreign body, there is a technique that everyone may be doing the same bronchoscopic technique, intermittent apneic technique. Definitely comes with some injury to the trachea, but we have extended up to 45, we have done the cases up to 45 minutes. Even I have got a video recording of these, the case done in pediatric cases up to 45 minutes. And if the sir allows, even I can show 3 minutes of video where how we conduct a tubeless surgeries.
I think we have time. Anil, please.
Shall I share, sir?
Please. It's there in your laptop?
Yes, sir. Yes, sir, it is.
Please.
Sir, Dr. Arun from Hyderabad here. We have done 2 to 3 cases of tracheal resuscitation. I mean, not tracheal reconstruction, but tracheal stenosis post-OP poisoning. And I was just listening to the sir, and the equipment is quite very simple.
Okay.
The main thing in this is the principle is the we are sending oxygen of flow rate of 70 liters, and at the same time there is a lot of humidification going on. So the oxygen particles are broken down more into micromolecules, and the humidified oxygen is carried to the deeper parts of the alveoli. So the main thing is regarding the amount of oxygen that would be used. There won't be much of any sound at all. It's only the amount of oxygen flow, 70 liters. So that's the reason it is not used much. It is used mainly when it is required.
Okay.
Yeah, sir. So
probably what Dr. Arun is talking about is, I think, Thrive.
Of the
Thrive or HFNO.
micromolecules.
Probably he's not talking about high frequency ventilation. It's maybe Thrive or HFNO. I think.
He's talking about HFN.
Yeah.
Shall I play the video, sir?
Yeah, please.
This is a case we have. The case of posterior vocal cord polyp.
Yes.
Vocal cord polyp, and this is how it looks when we see without tube. And this particular patient is paralyzed. The hemodynamics of this patient, absolutely rock solid.
Can you give a little bit of your comments, Anil?
This case we started at 5:55 in the morning. You can see the time in the monitor.
Okay.
And this case took almost 40 minutes to complete.
Okay.
And in any time in between, we never disturb the surgeon. fortunately, patient was an young patient who monitored the oxygen saturation throughout, not even 99 in any point of time. You can see the monitor there. You can see the time, it was 6:20. And the thing is, with careful selection of the patient again, and the surgeon was able to complete, and everyone can ask how to achieve the hemostasis in the situation. This is where the surgeon's skill and their patience and their cooperativeness is required. We always use adrenaline balls or adrenaline gauze or the pad that was used to ensure the hemostasis in these cases. And in case there was one case of major bleeding, where how to secure an airway was, we passed in the ventilating bougie through the surgeon's laryngoscope. Over that, we threaded the regular endotracheal tube. In another incident, we just inserted microlaryngeal tube through surgeon's laryngoscope. And we just removed the surgeon's laryngoscope and we inflated the cup and we ventilated the patient. This is how we learned over the time how to troubleshoot the common complications.
Okay.
I think Anil, with this case, you did immediately after the surgery, held the mask with ETCO2 and then you recorded the ETCO2 also.
Yes, sir, it is there, sir.
And ETCO2 was not very high.
Not very high, sir.
Correct. I remember that.
Yes, sir. It just comes, sir, now. Is at the conclusion of the surgery. Now, as the surgeon concluded, immediately now this is the first time I was holding mask and started ventilating post procedure, and we can see the end-tidal carbon dioxide. It gave us a rough estimation. It was never high. It was not too high in this particular patient. And patient recovery time, it took about 7 to 8 minutes, probably 9 minutes, and he was away. Timing there, it is 6:58 now.
Okay.
Thank you, sir.
Yeah, it's a good show. So, in fact, there are some questions about nitrous oxide and inhalation agent. So, per se, being a tubeless procedure,
We cannot provide.
it's a limited scope, if at all, for any inhalation technique per se, consistently. So, I think ideally an intravenous route would always be advisable. Yes.
No, only that route we can provide, sir. Because unless we're using the intermittent apneic technique where we are ventilating in between, the only way of providing anesthesia is TIVA. Yeah.
TIVA can be done. Even there have been some TCS publications also which have been done with respect to the laryngeal procedures. That's an important one. And of course, ideally, if the nose is free, I think some sort of no desat should always be increased, right? So some sort of oxygenation is continuously being provided to the patient. Of course, keeping in mind the requirement of the additional oxygenation if we are not using a nasal access. So that's the most important consideration. And front of neck access, as you say, would be difficult. But if the pathology allows, if their landmarks are good, then we should have identified them in the preoperative periods and be ready for an intervention. In fact, it's pure out and out an airway procedure. So, in fact, preparation for a difficult airway management and an airway cart must be done thoroughly in the preoperative period itself, straight away, unlike other cases. Is it not? So, there should be plan A, B, C, D, or whatever.
It is must. Without that setup, we should never venture this technique.
We should never use this technique. That's the important thing. And I think this being an airway procedure, whether it is a limited one or a longer lasting one, we should be prepared to monitor for and manage any complications related to the airway. the usual laryngospasm or laryngeal edema or supraglottic edema and other things. We should be on guard against all these things also. So that should be part of our regular management of the patient per se. Then, of course, Dr. Pundit says that we have been doing this tubeless procedures for foreign body, especially in pediatric age group. Yes, we have got the ventilating bronchoscopes which are available, the Jackson type which are available, which we have been doing a tubeless procedure overall, right? So I think this many are the questions. Anybody else would like to contribute?
May I, sir?
Yes, sir. Yes, sir. Right, sir. Good
Sir,
evening.
Good evening.
Yes, sir.
Nice presentation, sir. As you had mentioned regarding the foreign body.
Yeah.
When we are removing foreign body, if there is saturation is going down or difficulty in ventilation, we come to the trachea, and without removing the bronchoscope, we can put a endotracheal tube that get well fit in the bronchoscope lumen, and we can able to ventilate whenever the patient gets oxygenated well, then can continue the foreign body removal again.
Yeah.
If side arm is not working or venturi is not effective, this will very well ventilate the chest.
Yeah. So there is no risk of deoxygenation at least.
Yes, sir.
Non-stop to the patient.
Yes, sir.
So it's all, as you say, we have done that, and it's a matter of experience. So it's not
Yes,
for the novice to try to attempt this in the beginning. So we should be well versed to manage the patient. Thank you, sir. Thank you very much. So I think there has been good participation, Dr. Anil, and we will be relieving you for the 8 o'clock next session.